Good afternoon, everybody. It's Dr. Randall Wolf here.
Hello.
I'm at Texas Medical Center, and we are in Houston, Texas, Methodist Hospital, and this is a DeBakey CV Live event. As you know, first Tuesday of each month, 5 p.m. Central Time, is when we bring to you information about AFib, specifically minimally invasive surgical treatment of AFib. Last month we had on Dr. Otsuka from Tokyo, Japan. He is a friend of mine. He trained with me. He has a busy AFib practice. We got a lot of good information, a lot of good feedback from last month's 1-hour presentation with Dr. Otsuka. Sandra Schrameyer, many of you may know, she is the administrator for the forum on Facebook. The forum is Wolf Minimaze, Live AFib Free. And there are many questions every day about different aspects of the minimally invasive surgical treatment of AFib. And Sandy's been really an angel trying to answer these questions. And it seemed appropriate that we take an hour out and talk about some of these questions. Now, in addition to some questions that Sandy has collated, you may also join us live. That's the beauty of this forum tonight, this webcast, is you can join us live, and Sandy and I will take your questions during this hour. You have two options, and they're on the screen. You can either be on your phone or you can be on your computer. If you're on the phone, you go 37607 and then text DeBakey, D-E-B-A-K-E-Y, and you can ask your question. If you're on your computer, you go to pollev.com, that website. You enter the word DeBakey, again that's D-E-B-A-K-E-Y, and then you respond to the questions that come up. And that way you can ask us any question. There are no stupid questions. This is a complicated area, and there are many questions that are appropriate. There aren't any bad questions. So please, you don't have to wait till the end of the program. If you'd like to get your question in towards the front, I will take the questions and intersperse them into our conversation as we go along. So first come, first serve on the questions. Either join on the web or join by text on your phone, and we will work your questions in and hopefully be able to answer your questions. Between myself and Sandy, we have a lot of knowledge about AFib, and hopefully we can help you. There are two patients for Minimaze surgery tomorrow. They're both here in Houston. One came from Arizona, the other from Encinitas, California. The person from Encinitas is Wayne, and I asked him if he wanted to join us, and he said yes. And interestingly, he did not find out about us from the Facebook forum. He found out about another way, which he'll tell us about. And so we may ask Wayne a few questions as well, or he may have a question for us. So that's the format for this hour, and the questions are starting to come in, and I like that. The earlier you get your question in, the quicker we can get to it. So the rest of this hour, we're going to concentrate on questions that come from the forum, plus your questions out there in the ether from all over the country and other countries about minimally invasive treatment of AFib or AFib in general. Before I introduce Sandy, I'll take the first question just to get us started. Do you still use an external pacemaker if someone already has a pacemaker? And the answer is no. I'm probably the only person in the world, probably the universe for as much as we know, that leaves a wire on the outside of the heart at the end of the Minimaze procedure. Why? Well, sometimes, particularly Wayne's situation where your heart's been out of rhythm for a long time, and you're often on medicines to slow your heart rate. You're out of rhythm, but your heart rate's not too fast. When that heart goes back in rhythm, the heart rate can be very slow for a while until those drugs wear off. If we don't have a wire on the heart, then the heart's very slow and we have to use medications to try to increase the heart rate. But if we leave a little wire next to the heart, which I've done for 18 years, then we can pace the heart. We don't have to give any medications. That wire is not attached to the heart. It's not part of a permanent pacemaker system. And before the patients go home, we simply slide the wire out. So it's been extremely beneficial and has allowed us to keep our pacemaker rate after AFib surgery extremely low. Less than 10 patients over 2,000 patients who've had the Minimaze have had to have a pacemaker afterwards, which is an incredibly low rate. And the reason is that heart rate is only low for a few days, and then it usually starts to come back up. So why implant a $30,000 pacemaker if you really only need it for a few days? So that's why I leave a wire on. And the answer to this question, some people say, I have a pacemaker, can I still have the Minimaze? The answer is absolutely. Then do you still need the external wire? And the answer is no. But the external wire is just a tiny wire and it just slides out. Sandy, there are a couple other questions that fit in with your questions. And I think I'd like to introduce you to get you in on this, and then we'll work these questions in. Sandra Schrameyer is a medical person. She's a registered nurse. She knows a lot about AFib, not only from learning in her medical profession, but also as a sufferer from AFib. And Sandy, I know you have two homes. I didn't ask you which one you're in. Depends on the day of the week. But anyway, welcome back to the program, and thank you for being the administrator of the Facebook forum, Wolf Minimaze Live AFib Free.
Thank you. Thank you.
Where are you today?
I'm home in Wisconsin, by the way. I'm home in Wisconsin.
You're in Wisconsin. Okay.
I am. Okay.
So for the listeners out there, the history of this forum is that when my daughter was in an undergrad at Indiana University, she started this on Facebook. So this would have been, I don't know, maybe 10 years ago. And there were about 9 people on the forum. Sandy resurrected the forum. And Sandy, you went from 9 people to how many people are on the forum now?
I think it's close to 780.
780, because it's a useful place for people to trade information and get not only information, but some knowledge and hopefully some wisdom. And I'll repeat this, I've said this before. The internet is great, but it has some unintended consequences. There's a lot of information there, but it doesn't tell you what's good and what's bad and what doesn't matter. Some people now call it misinformation, but that's misleading too. But there's, particularly in the medical field, there's a lot of information there, but the knowledge is not that great. And you have to sift through all that information to try to get the knowledge. And even harder to get is the wisdom from the internet. It's there, but it doesn't say, I'm the wisdom against all this other information. So the purpose, the way I see the purpose of the forum, is to take all these questions and then help people get some knowledge and maybe even some wisdom. And Sandy's voluntarily has taken over this as the administrator of the forum. And Sandy, it's a private forum, but you pretty much let almost anybody on, right?
I do. I don't keep it open because people do talk a lot about their medical problems, and you just kind of don't want to put it out there. But when they join privately, we kind of all know we talk about our things, but it's all they have to do is join.
Yeah. So they just go to Facebook and they put in Wolf Minimaze Live AFib Free. It brings up the site, join. And then you ask to join. Is that right?
Correct.
And if they ask, you're usually on it within a day or two, right? Or sooner.
I within a couple of hours. I check my phone all the time.
Okay. I want to take a question now that we got Sandy on. I had my first and only episode of AFib 7 months ago and went to the ER and had a cardioversion. I've not had another episode like that. What do you do? Well, that's already called persistent AFib because the patient's had a cardioversion. But we generally don't recommend an invasive procedure, either catheter ablation or the Minimaze, after only one episode. Now, What's important to know is that about half the people that have AFib feel it. They know the second they go in, they know the second they go out. The other half just feel kind of tired, fatigued. They realize that they can't walk up the flight of steps to the bedroom as well as they could a year ago, but they don't really feel it. So the point here is that if one wants to be objective about how much AFib they're having, you really have to have a monitor. There are monitors that fit on the outside of the chest, like a Band-Aid, that can be worn for a couple weeks. We use several of those in the office. And then there's also one that could be implanted that's under the skin, and that battery now lasts for about 5 years. And that allows us to objectively determine how much AFib a person has. And sometimes it's very interesting. I mean, some people have mainly nighttime AFib, and they don't know it. But we monitor them, and we find out, in fact, they have a lot of AFib. So one thing to consider is to be monitored for 2 weeks or have the link put in. I would recommend that because it's very objective, and it doesn't go in the heart or in the lung, it goes under the skin, and it gives us information every day on whether or not there's any AFib, and then every month it gives us a readout of what % of time the heart's been out of rhythm. So it's been extremely helpful in patients who don't know what to do. Would you agree with that, Sandy?
Absolutely.
And the link,
yeah, great.
You're a believer in the link, right?
I certainly am. I have mine, and it's just peace of mind.
Right.
You know what's going on with my heart all the time.
Right. I have a mix of typical and atypical atrial flutter. Would the Wolf Minimaze likely address those? Usually if someone has typical and atypical A flutter, they've had an ablation. Atypical A flutter is extremely rare before ablations were done. With catheter ablations, that's very common. One of my patients came back to have a catheter ablation of her atypical atrial flutter after the Minimaze, but she'd had prior a couple of ablations. So atypical A flutter is commonly seen after catheter ablation, not the Minimaze, catheter ablation. And initially, I did not treat that because I did not conceive this procedure to treat atrial flutter. It was put together to treat atrial fibrillation. However, I found out that in some cases where there was A flutter and we were there for some other reason, the Minimaze did treat the atypical A flutter very well. And the reason is, if you look at why people have catheter ablation, it's to isolate the pulmonary veins. But when we go in with the Minimaze, I check the veins, and generally they're still very active, which means that the veins weren't really isolated in the first place. And if the vein's not completely isolated with a catheter ablation, guess what you get? Atypical left atrial flutter. So it turns out the Minimaze can be a treatment for atypical left atrial flutter after a catheter ablation. It is not a treatment for typical A flutter. Typical A flutter is very nicely treated with a catheter ablation, over 90 chances out of 100 of good success. Any other comments on that? That's probably a question you get from time to time.
I get that question all the time. And in my personal opinion, my personal experience, I had flutter after I had 3 failed ablations, and then I had my Minimaze. But yeah, I had flutter for almost a year, thinking that we were going to need to do a catheter ablation, and it actually subsided. I haven't had it since.
It goes to the fundamental question, which is, what are we treating? And I have a fundamentally different approach to AFib in that I believe the AFib is coming from an imbalance of the autonomic nerves.
Yeah.
So burning up the heart never made sense to me. The heart is a muscle. There are no nerves on the inside of the heart. It's just muscle. So burning and burning and burning to get deep enough to get to the nerves, which are on the outside of the heart, seems like a long way to go, whereas if you approach it from the outside of the heart, you're right on the nerves. We can test the nerves, we can see everything, and we can also do an isolation of the pulmonary veins, which is what is achieved with a catheter ablation, but we can do it in about 12 seconds. But we also can see the nerves, and we can close the appendage. So it's a fundamentally different approach, and a lot of people that have this atypical flutter have an incomplete ablation because it's not that easy to do a catheter ablation, frankly, and that leads to the atypical flutter. There are whole conferences on atypical flutter after catheter ablation. If I can't take antiarrhythmics, will the Minimaze work for me? Also, if I had a stroke from AFib, would I still be able to get off blood thinners after the Minimaze? I'm sure you've heard that question many times too, Sandy.
Yep. Yeah.
So let's take it from the top. If you can't take antiarrhythmics, will the Minimaze work for me? Yes. That's not an unusual reason. In fact, all antiarrhythmics will eventually fail. They just do. Even people where it works for a while or for years, then they usually fail. And there are a lot of side effects to the antiarrhythmics. So it's not unusual for us to hear people who have had failed antiarrhythmics. I don't know if personally you had that or not.
I didn't. I couldn't take them. I couldn't take any of the meds. It was just, I couldn't function. Literally.
Side effects.
I'm sorry?
Side effects.
Exactly. I couldn't function. I just, my pulse and my blood pressure went so low, even at the very lowest doses. There's just no way.
And in your case,
then I was told the only other option was an AV nodulation and a pacemaker, which I refused.
And for those of you out there, Sandy's cautionary tale is a good one. There is another option besides an AV node ablation and a pacemaker. If you can't take antiarrhythmics, if you've had 3 ablations, although I will say if more and more patients are now coming for this with no ablations, and that is a better chance of cure if there have not been previous ablations. Sandy, I think when you talked to me earlier today, this was one of the ones you wanted to talk about, was can AFib be hereditary?
Absolutely. Absolutely. It's very familial.
And that's something you get questions about that.
Yeah, on the forum today, people were talking about just how many in their family had AFib. So my dad had AFib. That's the only one I know of. But yeah, it definitely is familial.
Sometimes we see 4 out of 5 brothers and sisters have AFib, but then one doesn't get it. So it's not
Right.
complete penetrance. And there are a lot of people that are trying to look at this, but it's, and there have been some genes that have been isolated that seem to be part of this AFib situation, but we still got a long way to go to figure it out. But can it be hereditary? Absolutely. Anybody in your family
For
have
what
it?
it's worth, just about 2 or 2.5 years ago, my brother went into AFib. An older brother.
Older
believe it
brother.
or not. I preceded him by probably 10 years, but it did.
So Wayne, is he waiting to see how you do before?
He really is. He's anxious to see how this works.
He sent, what a great brother. He sent you in first. Huh? But he is waiting to see you, right?
He really is, yeah.
Is he out of rhythm all the time too? Or?
We don't know, and this would be an interesting question.
Yeah.
His electrophysiologist refused to put a Holter on him to see whether he's out. He just said, "You're out all the time." And I said, "You didn't wear a Holter for 2 weeks? He just believes you to be out?"
Yeah, well, that's the cardiologist may be right.
Well, sure.
If each time an EKG is done and the heart's out of rhythm, then there's a good chance that it's out of rhythm all the time.
Okay.
Pretty good chance. The more difficult scenario is that a patient has an episode of AFib and they go to the emergency room. By the time they get there, they're back in rhythm. And that's a lot harder to sort out.
Yeah.
But your brother is probably out all the time.
And he has had a catheter ablation.
He has had a catheter
Right.
ablation. Okay. Well, then
And
another
2 cardio versions.
Another point is that oftentimes when someone goes to the ER, even a doctor's office, and they say you're out of rhythm, they always say it's AFib, but it's not. And in Sandy's case, she had AFib, but she also had atypical flutter. But a lot of places, when you go in, they will say, "Oh, you're back in AFib," when it's really flutter. So one thing we've learned is when someone talks to us about your brother's situation, we say, let me see the EKGs. And a lot of times it's not AFib, it's a flutter.
Interesting.
Right, Sandy?
Right.
You've seen that too.
Yeah.
Is there a reason some people feel banding and others don't? I think this is a question after the Minimaze. The incisions for the Minimaze are between the ribs on each side, just below the armpit. And some patients complain of a tight band or like a belt around their chest for several weeks. And I think the reason some people may feel it and some don't, there are a couple reasons. One, if the more overweight somebody is, I think the more they feel that. But also, everybody's nerve distribution's a little different. And it depends on whether or not maybe the port was close to a nerve and irritated it. But Sandy, you've been through this. Tell us your experience.
I did not feel that at all. I didn't have any banding. So when somebody explains it to me, I don't quite understand that because I didn't feel that. But I do know that they say that it does go away after a few weeks.
My echocardiogram report states that the left and right atria are significantly dilated, but reading the abbreviations on the report, all I can find, it might be related to LA dimension 3.8 centimeters, which from what I read is normal. I'm concerned that the enlarged atria would reduce effectiveness of ablation. Can you discuss? There is a good correlation between the size of the left atrium, and I guess we better back up a little bit. Your heart has 4 chambers, 2 in the top. I didn't bring my model in today. 2 in the top and 2 in the bottom. AFib, in AFib, we're discussing the 2 chambers in the top. Forget about the bottom ones. That's not involved with AFib. AFib are the 2 chambers in the top, and most of the AFib comes from the left one, called the left atrium. And there have been many studies over the last 50 years that have correlated the size of the left atrium with the chances of getting back in rhythm. And in general, once there's over 200 milliliters in the upper chamber, the chances start going down that the heart can get back in rhythm. Now they may go from 90 to 80, 80 to 70. Another way to look at it, instead of the volume in milliliters, is the size of the left atrium. And 4 centimeters is considered a normal size. But 4 centimeters in someone who's 5'2" is not the same as 4 centimeters who's someone, how tall are you?
6 feet, exactly.
You're 6 feet tall. So it's not corrected for your body size. But in general, what I've found is once the left atrium is greater than 5.5 centimeters or over 200 milliliters, then the chances of success start to go down a little bit. Now, if I see a left atrium that's 3.8 centimeters, you're fine. You're in the top % of people who are going to get a good result. If signals are found to come from the left atrial appendage, would those be addressed during the Wolf Minimaze because the left atrial appendage is clipped? Good question, and the answer is yes. If I go to my slide, if we can put up the slide on the left atrial appendage, there's more than one reason to close the left atrial appendage. It's important for 4 reasons. One, it dramatically decreases the chance of stroke. If someone takes Eliquis or Pradaxa or Xarelto, you decrease your chance of stroke by 60%, AFib stroke, which is good, but it's not that great. 60% is not something you'd want to bet on. I don't know, maybe for the Super Bowl you could, but not for your own health or for your own stroke rate. If the appendage is closed, you decrease the chance of an AFib stroke by 97%, and you don't have to take any blood thinners. So that goes along with the second reason, stop the blood thinners. One of the patients recently has very bad Crohn's disease. We've had many patients with that. They can't take blood thinners. They don't do well. They have GI bleeding. Now the third one addresses the question. Eliminate the AFib focus, and that's by closing the appendage, we eliminate any AFib focuses on the outside of the appendage in the nerve area. So it's very important. Now, if you use a different technique, say a Watchman device from the inside, which is more of a cork on the inside of the appendage, that will not decrease the signals from the appendage. Only closing it stops those signals. And lastly, and this is a new one within the last couple of years, it's been documented that if the left atrial appendage is closed, blood pressure is much better controlled in people who have high blood pressure. I've known that for a long time, but I never reported it. And even our orders for years have said, after the Minimaze, immediately cut any blood pressure medicine in half and hold it for a systolic pressure less than 120. So a lot of patients don't even use it right after surgery. So those are some of the reasons that it's important to close the appendage. And while we're on it, let's look at a quick video of what it looks like. So this shows the clip I use. In the first 1,000 patients, I closed it with a stapler, but now more commonly I use the clip. That's the appendage. And you can see these incisions aren't big enough to put our hand inside the body. The heart is beating. We haven't stopped the heart, but we have a very good view through the scope of the appendage. The appendage is that more bluish, purplish thing. The heart is just to the left of the clip. And now the clip's been deployed, and we remove the deployment device, and there's the appendage, and it's closed off. So now the appendage no longer communicates with the heart. And this part of the procedure takes just a couple minutes. Sandy, questions about the appendage? I think there was another one that you encounter from time to time.
Yeah. People think that the left atrial appendage has got to have some kind of purpose, and by clamping it, are there any side effects?
Yeah, well, the biggest side effect is it increases the chances that you'll stay in rhythm.
Exactly.
But there used to be an argument that it was a reservoir for the left atrium, and was important in the function of the left atrium squeezing blood into the left ventricle. But in fact, what happens when the ventricle fills, it sucks the blood out of the left atrium. So it really doesn't matter. And there was a friend of mine in Europe who felt this way, that it had a function and it shouldn't be closed. And he did an experiment where he put catheters into the left atrium during a procedure, then closed the appendage and measured the pressures. And after 10 minutes, it didn't make a bit of difference. So we have objective evidence, it's been published, that these superstitions about the left atrial appendage have been resolved. It doesn't make any difference. Let's see. How can a patient differentiate between experiencing AFib and aflutter? Sandy, I'm going to ask you that one.
I think they felt very similar. I think it was difficult. I know that when some people go home and they experience some flutter after, which is quite common after the Minimaze, they wonder, am I having AFib or am I having a flutter? Generally, AFib will be more irregular. It does not have to be fast. Flutter is generally faster and more regular, but it can be unregular as well.
Yeah. And we should also add the caveat, after Minimaze or even catheter ablation, the first 12 weeks the heart's healing. So a lot of these abnormal rhythms are not permanent. And you have to let things settle down, not jump to conclusions. And that's a hard thing to do after you've done something for your AFib, but you have to give it a little time. You have to let the paint dry, right?
I keep saying that there's a process to get to that finish line. And,
right.
We just, everybody's impatient. They just want it to be done and over with. And it doesn't work that way. It is a process.
There are really two steps to this. There are two results we're looking for. One is to dramatically decrease the risk of stroke. And that's usually accomplished right after the surgery. But that's not something you really feel. The second one is to be AFib free. It may be right after the procedure. We've had many patients that have never had any more AFib. But if they've had previous ablations, or they may have an underlying flutter, sometimes you see AFib and aflutter, but the predominant rhythm is the AFib, and then when we take care of the AFib, we see the flutter. So yeah, you got to give it a tincture of time. Sandy, I'd like you to go over some more of those questions that you have at this point. Again, for the people that are out there, we can take more questions either by text or by the web. It's at the bottom of your screen. You can you can get a hold of us by the phone or your computer, and we'll try to get your questions on during this hour. Sandy, you get a lot of questions, and you're really an angel taking some of these. Why don't you go through a few of them?
Okay, we kind of answered quite a few of them already, but one of the things I get a lot is about vagal AFib. I have this, I have that, I drink cold, I just bend over to tie my shoes, I go into AFib. Is this vagal AFib? How do I know I have vagal AFib?
I believe, as you know, that most people who have what's called lone AFib, that means you don't have coronary disease, you don't have a valve problem, you just have AFib. Right. I believe that most lone AFib is vagal AFib. It starts with imbalance of the nerves. Now, if we take 50 people and ask them what their triggers are, we get about 40 different answers. So it's true that alcohol and obesity and sleep apnea all exaggerate the AFib. Unfortunately, a lot of times, even if you lose weight and take care of your sleep apnea, you still have it. Maybe not as much, but you still have it. But there are, if you got 100 people, you got 90 triggers. And it probably is related to the vagus nerve. Many people have told me that after the Minimaze, their stomach problems go away. Well, that nerve, after it gives the branches off from the heart, goes to your stomach. And a procedure to stop the acid in the stomach in the 1970s was to cut the vagus nerve. And it would make your peptic ulcer go away. So it's the same nerve, and it has thousands of branches in our body, but a couple main places are the heart and the stomach. Next one, Sandy.
Everybody is curious about chest tubes. Does everybody get chest tubes after, and really what do they do?
Okay, well, hopefully the chest tubes do nothing. The chest tubes are there as a precaution. If there's increased fluid, the chest tubes will drain that fluid. It's very rare that there's increased fluid. The second is if there's any air leak, the chest tubes will remove that air. Some of the patients we operate on, Wayne could be one, we don't know, have had prior trauma. They've had a pneumonia. We've had some people that have had COVID and had bad adhesions between the lung and the heart. And those adhesions, a scar, has to be freed from the heart so we can get to the heart. In freeing that scar, you can get small air leaks from the lung. The lung is not a balloon, it's more like a sponge, but it can still leak a little bit of air if you've messed with it. So if the lung has to be cleaned off the ribs, you had trauma to your ribs, we could see it on your chest x-ray. It may be fine, but it may be stuck there. Freeing the lung from the ribs or from the heart can cause some air leaks, and that chest tube gets that air out until that heals. So it has an important purpose, and sometimes I've taken the chest tubes out on the same day. Some people have complained, they don't have any air leak, there's not much fluid, I'll take it out. But I still think it's important as a precaution. They come out the next morning. Most people don't even know when I take it out. They don't feel it because it's through the hole where the scope was, and the tubes are smaller than the scope. But if there's an air leak, then we leave the chest tube in until that air leak stops.
I get a lot of questions about PVCs and PACs, that sometimes they feel worse than AFib. And is there anything that can be done about them?
Great question. The key to differentiating AFib, A-flutter, and by the way, everybody, there are about 100 different atrial arrhythmias. We focus on AFib because it's by far the most common. We talked about A-flutter a little bit, but there's 98 more. PACs is an extra beat from the atrium, but it's not AFib, it's not A-flutter. And sometimes after that extra beat, there can be a pause. Sometimes the extra beat comes from the lower chamber of the heart, which, as Sandy said, that's a PVC. The V is for ventricular, PAC, the A is for atrial. They're extra beats, they're quite common. Generally, they are not treated, they are a benign issue unless they're all the time. But occasional PACs and PVCs with a pause, you don't treat it. And the beauty of the link is we can tell what it is. So if someone says, I think I'm going into AFib, and they have a link in, they can hit a button. I see a timestamp. I can go back and look at that, or you can even do it on your Cardia. And I can tell you if that's AFib or if it's just a PAC. But the link is great because then we know.
Talking about the link, a lot of people have questions about how the link is monitored by your office. If they have an issue, does it alert you or Kimberly that there is an issue? And why is the link not put in during surgery? Why do you wait 5 or 6 days afterwards to put it in?
Okay. The link is not monitored by me every day. It would be impossible to do that. If a person thinks they're having an issue, they can hit a button on their phone. It gives it, or the remote, hit the button, and it gives us a timestamp. And then the best thing to do is, or first of all, remember, whatever happens today on the link, I don't see till the next day, because it downloads in the middle of the night. Right. So if you're having an issue today, hit the timestamp or take note of the time. The next day, send a message to Kimberly, our nurse, and that's we should put that phone number up there from time to time. It also tells you how to get in touch with us if you have AFib, so we'll put that up there. But get in touch with Kimberly. The best way is to send her an email or even go into my chart and leave her a message. She's very good at checking those messages. And then she'll alert me that somebody had an issue yesterday and we'll look at it. But it does not alert us to every episode. And the second part of the question is, why don't we put it in at time of surgery? I did for a while, and there's some advantage to that, but there's some disadvantage too. I kind of like to see how things are going to sort out for a week after surgery before I put it in. And also there's an insurance issue with some insurance companies where you can bill for it if you do it in the office a week later, and I put these in the office. But it's very complicated if it's done in surgery, and sometimes the patient might have to pay. So I try to keep it very clean and generally do it about 5 to 7 days after the surgery in the office. It's local anesthetic, it's under the skin, it takes about 15 minutes, and that's a clean bill, not messed up with the hospital bill. So there have been a couple of different reasons from time to time. Sometimes I didn't know if maybe the patient might need a pacemaker, and I didn't want to put a link in and then put a pacemaker in 5 days later too. So it's just worked out for, I guess I could say, more than one reason to generally put it in a week after the procedure.
Okay. Some questions about how long do I have to be off of work? When can I start to exercise, and when can I start lifting weights?
There are no strict restrictions after the Minimaze. A lot of it has to do with how big a person is, how overweight they might be, how much they were getting around before the procedure. Generally for upper body, you're stretching this skin here when you lift weights. You should wait a couple weeks for that. Lower body, the more walking you do, the better. We have a lot of people, Sandy, that come here, as you know, from all over the country, and after their surgery, they're in the hospital a couple of days. They go to the art museum, they go to the Natural Science Museum. They really turn it into a sort of a medical-based vacation.
A little mini vacation.
Yeah. So the more you walk, the better. Upper body, I think you need to wait a few weeks, let that settle down.
I know that you like to use amiodarone on some people before to calm the heart and after to keep the heart in rhythm. People are afraid of the amiodarone name, and it's got some bad raps, but short term, I've tried to convince people that it's okay to use short term, so maybe you can reiterate.
Amiodarone was FDA approved years ago for life-threatening ventricular arrhythmias. And again, this whole discussion is about atrial arrhythmias, not ventricular. AFib is an atrial, upper chamber arrhythmia. The drug amiodarone was okayed for life-threatening ventricular arrhythmias, and in high doses, 800 milligrams a day.
Right.
But we don't use amiodarone for the ventricle, we're using it for AFib, so we use 25% of that dose, which is 200 milligrams a day, and that's pretty well tolerated. And what we've seen is if your heart's out of rhythm all the time, and you want to have this procedure, it's better to be on the amiodarone before the procedure for a couple of months and after the procedure for 12 weeks, and you generally get a lot better result. If the heart's only out of rhythm from time to time, then I usually don't use amiodarone pre-op. Wayne, you've been out of rhythm for maybe 6 years or more, we don't know.
Right.
So I think you did start the amiodarone
just about a month before.
In December?
Before now, yes, early December.
Early in December, so that's really that's maybe 2 months, isn't it? This
You're
is February.
Right. That is 2 months.
Which is great. So has it bothered you much?
I haven't noticed any difference.
Did you look it up to see if
I did, absolutely.
Okay, because the more you look it up, the more you start getting the side effects. But you didn't, you don't think, right?
No.
Okay, and that at the lower dose, that's pretty typical. Again, this is an art. And even on a low dose, if someone's on it for more than a year, then it's important to check the thyroid function and the chest x-ray. But our experience is less than a year at a low dose, pretty safe drug. Not in everybody, but not everybody can take aspirin and it's considered safe. Not everybody can take Tylenol. Some people take Tylenol and they go into liver failure. So there's no drug that's perfect. It's always a risk and a benefit. And what we've seen is low dose amiodarone has a lot of benefit and a little risk, but it's never zero.
Another question I get is it normal for your heart rate to be elevated after the Minimaze and for how long? I know mine hung in the upper 90s for, I want to say, maybe 6 weeks, maybe even a little bit longer, before it slowly came back to normal.
Yeah, Sandy, common question, and yes, it is elevated after the Minimaze. These ganglionic plexi, which are the little nerves on the outside of the heart that control the AFib and can initiate AFib and can sustain AFib, are a mixture of sympathetic and parasympathetic nerves. And it gets a little complicated, but I think I can say it simply. The vagus nerve tends to slow your heart rate. The sympathetic branches tend to increase the heart rate. And there's an imbalance there. And when we do the Minimaze, we take out those mixed nerves and you primarily get an anti-vagal response, which means the heart rate goes up a little bit. The vagus slows your heart rate. We cut some of that out so it's a little bit higher for a while after the procedure. It can be for months. And that's normal and nothing to be concerned about.
Another question is, when I go home, I know I'll need a doctor. Do I need an EP, a cardiologist, or can I just see my favorite general practitioner?
Another good question, and there's no one good answer for that. Some people say my electrophysiologist supports my decision to have this procedure and is willing to see me back. Same with the cardiologist. Other cardiologists say, go to Houston, but don't call me when you get back, which is sad because, I mean, the goal is to get patients better. So it varies quite a bit. Most patients have the link in, almost everybody. So for the first 6 months, I try to take over. After that, I think it's important to see your regular doctor. Certainly a year after the Minimaze, an echo is a good idea, an EKG is a good idea, and a regular visit. For the first 6 months, since your heart can go in and out of rhythm, it's probably better to let me handle it if you have a link. If you don't have a link, you really have to see your local physician earlier because I won't be following your rhythm as closely.
Okay. I do have people that say, I really want to be AFib free. I don't want to take any medications, but I'm terrified of having pain.
Yeah. Okay, well, let's start out with your experience. You had the Minimaze after 3 failed ablations, and you are a beautiful lady, and you're thin, but you weren't that thin when you had the Minimaze.
I wasn't. You know, and you know what? AFib was a warning for me, and I did try to lose weight, and I did try the old diet trick and the whole bit, and it didn't do anything for my AFib. I'm sure it helped me afterwards, but I did lose more weight after the Minimaze now because I'm just trying to keep my heart healthy. But
pain.
Yeah. I personally did not have a lot of pain. I didn't take anything but ibuprofen. And I've read others having a little bit more pain, but I never took anything any stronger than ibuprofen.
And I think you bring up the spectrum. Some people have pain after this procedure. Some people don't have any pain. And it's generally can be correlated with the BMI, which is your body mass index. If your BMI is greater than 35, that means you're really, really overweight. That means there's a lot more muscle and fat to go through to get to the heart. In some patients, I have to remove a fair amount of fat just to get to the heart. And I think all of that leads to more discomfort post-operatively. It can be that we had to scrape the lung off the chest wall or off the heart. There are lots of little things. Not everybody's the same. You know, here's a kind of a basic analogy. Someone can say, I broke my leg. Well, what's that mean? Well, it could mean you had a hairline fracture in your leg and it hurt for 6 weeks. It could also mean you had a compound fracture with the bone sticking out your skin and you had to have rods and pins, but it's a broken leg. Well, the same thing is true with the Minimaze and AFib. Everybody's not the same.
Right. So when can people want to know when they can have a beer or a wine after their Minimaze?
Well, first I ask them if they're in AA, because I don't want to give them permission to do that.
A beer or a wine.
But, you know, and we've talked about this before, Sandy, it's a good question.
Right.
We want to get people back to normal. And if normal is having a beer or having a glass of wine at dinner or having a cup of coffee in the morning, that's what we want you to do. We don't want you to live the rest of your life where you can't do these things. And I think that's what gets to some people. They've had ablations and they still have some AFib and they're told they can't do any of that. Well, what the heck? You got to enjoy life a little bit. So we found that if you get a good procedure, like the Minimaze, you can have a glass of wine. You can have a beer. And you can have a cup of coffee in the morning if you want. I just say in moderation.
Yeah, exactly. Sleep apnea. People want to know if after they have the Minimaze, can they forego the CPAP machine? And of course they can't.
There have been some studies performed, and the general consensus looking at these studies is that if the sleep apnea is not treated after the Minimaze, it was treated before, and the weight hasn't changed. Now, if you lose 40 pounds, you may not have sleep apnea anymore, but if you haven't lost weight, then the recurrence rate, if you don't do your CPAP after a treatment of AFib, increases by 44%. So if you have sleep apnea, you have to use the CPAP after the procedure, and I recommend patients use it in the hospital. If you're just sitting there in the bed after surgery watching TV, put your device on. It doesn't have to be at night. You can use it during the day, and it will inflate your lungs more.
Total days in Houston, is it 12?
Yeah, generally 12.
12, okay.
Because I usually like to see patients 1 or 2 days before the procedure, get a CT scan, particularly if there have been previous ablations or stents or some reason. You have to have a COVID test. We usually get that 2 days before. Was yours 2 days before?
It's today.
Today. Just to sort of get everything ironed out. And then we count on 2 or 3 days in the hospital, and then another 4 or 5 days in the hotel if they're not local. In Texas, local can be 10 hours away, but if they're not local, you know, I was interviewing one patient. He came to the office and I said, he mentioned the town where he was from in Texas. I said, I'm not familiar with that town. Is that close by? He goes, it's not far. It's about a 5-hour drive to get here. Well, you know, in most places that'd be another state, but not in Texas. So it varies, but generally 4 or 5 days in the hotel, and then see me in the office, do the link, and then fly out the same day. Okay. I know there's one big question. I want you to get it in, so maybe you should ask it now. Okay.
The big question, the number one question that I get asked all the time is if the Minimaze is the next best thing to a cure for AFib, and why is it not the standard of care, and why is it not done by every physician in every hospital in every state?
And it's a very reasonable question. The answer is several-fold. Number one is, a lot of people don't understand this. This cannot be done by a cardiologist or an electrophysiologist.
Right.
I know some people say, well, I had an ablation by my surgeon. Well, if you had a catheter ablation, it wasn't done by a surgeon. It was done by somebody who trained in internal medicine and then subspecialized in cardiology and then subspecialized in electrophysiology. But they didn't train surgeon. They started out their training in internal medicine. This procedure requires a cardiac surgeon, which means you were trained in surgery, in specifically cardiac surgery and thoracic surgery, and then you can do this procedure. So cardiologists and EPs can't do it. And for some of them, they say if we can't do it, you don't need it. That's some of it. Some of them say, well, if you want open heart surgery, go ahead. But it's not open heart surgery. Some of them say they've never heard of it. Some of them are telling the truth. Some of them aren't. I think most EPs have heard of it by now. Second reason, it's multifactorial. Second reason, it's a simple procedure, but it's not easy. Well, take, we're coming up on the Super Bowl. Throwing a football is not hard. It's simple. You grab it and you throw it to somebody and they catch it. That's simple. But it's not easy to get to the Super Bowl throwing the football, right? It's simple, but it's not easy. And a lot of surgeons confuse that, and a lot of people confuse that. Well, it's simple, so it must be easy. Same with basketball. Stand anywhere you want. Here's the ball. All you have to do is put it in the hoop. That's it. Put it through the rim. It's simple. But it's not easy. It's not easy when someone's waving their hands in front of you and jumping up who's 6'4". So what we're asking surgeons to do is not open the chest like they were taught to do, not go on the heart-lung machine to stop the heart, which they were taught to do, and do 99 to 100% of the time. 99 to 100% of the time, they're stopping the heart and working on a heart that's still. And we're asking them to do what's that?
And deflating the lungs.
Yeah, and well, that's not a big deal. And then also we're asking them to do this without putting their hands inside the body. So work on a beating heart, looking at a scope without your hands being inside the body. And for most heart surgeons, that's a bridge too far. Now, I know Toshi has told me the same thing in Japan. He goes out, he shows this to surgeons all over the country of Japan, from Okinawa all the way to Hokkaido. And almost all the surgeons say, I want to do this. It looks really simple, which it is, but then they find out it's not easy. For some of us, like Toshi is a protege of mine, it's pretty easy for him. I think it's pretty easy for me, but it's not for a lot of people. We make it look easy, but it's not that easy to do and get good results. And I've been to major institutions across the country. You name it, I've been there. And most of them have not had success trying to do this procedure. But, you know, we do it here 4 to 5 times a week. Knock on wood, everybody's gotten out of the hospital and done well. So that's another thing. If somebody says, well, I do 1 or 2 a year, it isn't going to cut it. You have to do it quite frequently to get good at it. Is that a decent answer?
That's exactly. That's usually what I tell people. I think they just had to hear it from you.
We're probably going to have to do this again because I know you have more questions, and we got more questions up here. What do you want to do? The questions on the screen or the questions on your sheet of paper?
Go ahead. I think everybody asked a lot of the questions that I had down to talk about, so go ahead and take questions. Okay, let's take a few, Sandy. And by the way, Wayne, thanks for being here.
Oh, sure.
Did anything come up that you wanted to get out? Because you're in a situation where your heart's been out of rhythm for many years. You're taking the amiodarone, and we're going to try to get you back in rhythm. And in Wayne's case, I mentioned this to Wayne earlier, it may be that the heart's still out of rhythm after a month because it's been out of rhythm for 6 years. It may require a cardioversion. If that doesn't work, we still have a catheter ablation at 6 months, and surprisingly to me, it works really well.
That's great.
So we have these options if the heart's been out of rhythm for a long time. Should we take a few questions here to finish up? Okay. I don't know if this is true, but I've heard from someone that when you have a catheter ablation, the doctor will put you in AFib to note where you need to be ablated. If so, is this the case with Wolf Minimaze? Well, that someone told you the truth. It is true with a catheter ablation, the heart must be put out of rhythm to do the mapping. It doesn't matter with the Minimaze. It doesn't matter if the heart's in rhythm or out of rhythm. It makes no difference at all. And we don't have to put it out of rhythm to do the Minimaze. In fact, it's a little bit easier in some ways when it's in rhythm, but it doesn't matter. Will I get to see my ECGs, they say EK or ECGs, after getting the link monitor? Well, I need to get a device. I'm scheduled March the 2nd with Dr. Wolf. Okay, well, you don't see your EKGs, and that's been a big issue with the link. I think patients should be able to see their EKG on their phone with the link. But apparently there's some HIPAA stuff, and it's difficult, and right now you do not see your EKGs on the screen. What we have done, what Kimberly has done, is she's taken the monitor, the link monitor results that we get in the office and send it to patients. So we can get you your link, your EKG. You just have to ask us and we'll send it to you. But you can't get it yourself. Let's see. I know that part of the procedures ablating the nerves, ganglionic plexi, are those ablated in a blanket fashion during the procedure? Are they stimulated and then ablated and found active? Yeah, it's a good question, very detailed. When somebody maybe looked at the procedure on the internet, we found that the ganglionic plexi tend to be in certain areas, and we mapped them out with Sonny Jackman and Ben Sherlog, who are electrophysiologists and very famous electrophysiologists. So there are about 5 or 6 spots on the right side and 5 or 6 spots on the left side on the heart where I know these little suckers live, and that's where we stimulate. And if we stimulate in that spot and we get a response with the heart just slows down dramatically, we know that's a GP, a ganglionic plexi. Now, as far as ablating them, if we put the clamp in the right place, we can ablate a whole bunch of them at once. So we can do a blanket ablation and then retest the spots to make sure we've gotten every spot. And as far as I know, I'm the only one in the world who does that. And that's why I wish we could get the word out to the few people who do some sort of Minimaze that they would test these spots. Because sometimes when you do the blanket isolation of these GPs, there's still one that's in a weird place. You need to treat it specifically and by itself. So yes, I do that. Here's a nice one. Good luck to Wayne on his surgery tomorrow. I'm scheduled for later this month. Thank you, Dr. Wolf and Sandy. We are a little bit over. It seems like the hour went pretty quickly, Sandy. I guess we're going to have to do this again because I don't think we got through all the questions. I wanted to mention that there was a patient who named it the Minimaze. I called it bilateral pulmonary vein isolation and closure of the left atrial appendage. One of the patients said, Dr. Wolf, that's never going to fly. And he's the one who named it what the name it has today. Final thoughts, Sandy, from your end.
Everybody pretty much answered the questions or asked the same questions that I was going to answer. But it's a great group. Everybody is so supportive. I'm really proud of everybody, how they cheer on the people that are going to have it, cheer on the people that had it, and cheer on the people that are thinking, is this even a procedure I want to go on and do?
Well, I want to thank you for all the work you've done to get this going, and you've helped a lot of people by trying to answer questions. I think my last point would be a little bit of a caveat. We'll put this up on the screen too. This shows how to get in touch with me, or you can also call Kimberly, and that is that the forum's a great place, but everybody's different. There are some people that never have an extra beat after the Minimaze. There are other people, example, a lady recently, I won't say her name, where she came from, but she drove a long way and she came here and she was in florid heart failure. And that's different from Wayne walking in off the street and sitting down here in the studio. I mean, she was on oxygen, and it took us 2 weeks just to get her to the point where she could walk around without oxygen.
Wow.
And then 2 weeks later, or maybe it was a month later, somehow we changed everything around to get her in and did the procedure, and she wasn't in rhythm right away. Well, I'm not surprised. I mean, that's a very different situation from somebody who drove here and is coming for the procedure. So I guess my point is that everybody's different. Everybody really is different. There's some common information, but there's also a lot of things that are specific to each patient. So some of the things you see on the forum may be particular to that patient, but that doesn't mean that you've got that. It doesn't mean that you're going to have that, right?
Yeah. Yeah. Well, people don't know, you know, when you read things, people don't know what they went into this procedure with. You know, there's pre-existing comorbidities, and they just don't know that. And no, that doesn't mean that's going to happen to you.
That's right. So the best thing to do is to talk to us, talk to Sandy, talk to me, talk to Kimberly, find out where you are on that spectrum. Are you the person that goes home the next day? Because we've had several patients, even in the last few months, that went home the next day. And are you on the spectrum where you've been in heart failure for half a year and now you want to get back in rhythm? Well, that's different.
Right.
So I guess that'd be my last point. Wayne, thanks for joining us this evening. Sandy, as always, thanks for all the work you do. I think you probably help more people than I do. And if you have AFib and you want some help, get a hold of us. There, you can go to wolfminimaze.com. A lot of people go there. You can go to the forum, Wolf Minimaze, and it doesn't obligate you to anything. I will talk to you. We may decide you don't need anything. We may decide you don't have AFib. I've seen people that have come in. I said, I need the Minimaze, and we do some studies and look at their EKGs, and they don't have AFib. They've got ventricular tachycardia and other things. So there's no downside to getting a second opinion. And talking to us doesn't obligate you to anything but an opinion. Sandy, thanks. Wayne,
absolutely.
Thanks. Mr.
Good luck tomorrow, Wayne.
Oh, what's that?
Good luck tomorrow, Wayne.
Thank you, Sandy.
Mr. and Miss Producers, thanks for all your help. It was a great show. Join us again in a month, first Tuesday, 5 p.m. Central Time, and we'll tackle some more questions and help you with your AFib problems. Thanks, everybody. Good night.
Bye.